Today we are going to talk about asthma. This is chapter 8 in your book. Guys, we are nearing the end of this course and the end of summer semester. I hope you guys have enjoyed it. I hope you've learned a lot. We still have a couple more weeks to go, so stay engaged. But we are today going to talk about asthma. And this is something that we've talked about since literally your very first class in pharmacology. I'm sure that um, we discussed it, or it was discussed in 1010. I know that Chuck discussed it in cardio A and P. So every class, we've talked about asthma. We've talked about the symptoms. We've talked about the treatment. We've talked about management of the disease process. So today we're just going to go into it a little bit deeper. We're going to start like we always do with our objectives. These are straight from your book. So today we are going to identify the common characteristics, manifestations, and diagnostic features of asthma. Okay. What does the assessment look like? Okay. How does the patient present? And then how do we diagnose it? We're going to talk about the incidence, prevalence, and risk factors, as well as prognostic determinants of asthma disorders. Prognostic determinants just means how bad is it and what does it look like in the future? Describe the underlying pathophysiology mechanisms in asthma. Sometimes we can just pinpoint, identify what's causing it. Sometimes we can't. Utilize diagnostic testing to establish a diagnosis of asthma and classifies the disease severity. Okay, so we're going to get into some diagnostic stuff, kind of pointing back to last semester and pulmonary function tests and chest x-rays and what they look like. Identify common risk factors and complications of asthma, and then discuss the 4 major components of effective asthma management. So what is asthma? Asthma is not something you think of as a genetic disorder, okay? But it is a complex genetic disorder. It can be carried through the generations. Multiple genes can contribute to the prevalence of asthma and to the severity of asthma. Severity is very variable. Okay, so you could have mild asthma, you can have severe asthma. A lot of people will say, I had asthma when I was a child, but I outgrew it. Okay, there's a lot of debate on whether or not that person really outgrew the asthma or whether, when you have a bronchial spasm, which is what happens in asthma, the bronchial smooth muscle tightens up. When you're a child, your airways are very, very small and you don't have as much branching going on. When you get into adolescence and adulthood, your airways are bigger. So you may still have the bronchospasm going on, but it might not be affecting you as much because there's a lot more compensation in your lungs. So the severity is variable. It's a chronic disorder. If people really don't outgrow it, like I said, their physiology might adapt to that bronchial smooth muscle spasm, but it doesn't necessarily just go away completely. Asthma as a disease has increased in prevalence over decades. There's a lot of different reasons that could be causing that, including change in atmosphere and pollution and urbanization everywhere. So the more city life we have, the more smog and or other chemicals that we breathe in, and a higher chance there could be of having asthma. Significant cause of disability and medical expenses and preventable death. Okay, so if we identify, diagnose, and treat asthma, most of the time it is a manageable disease process. And then it causes inflammatory changes and bronchoconstriction long term. So definition and diagnosis of asthma. In a broad category, asthma is heterogeneous. What do we mean by that? We mean it has many different parts to it. Asthma is not just one symptom. There are many different things that all happen when a patient is having an exacerbation of their asthma. When all those things happen, it causes the symptoms of the disease. It's characterized by reversible. That is so important. Asthma symptoms are reversible. Okay. If we give a bronchodilator to treat the bronchial smooth muscle spasm and it doesn't relax, and it maximizing that therapy does not reverse it, chances are something else is causing the bronchial smooth muscle spasm. So it's reversible and variable recurring symptoms. Okay, reversible, okay, obviously, we can reverse the symptom and make it disappear. Variable means sometimes it's mild, sometimes it's moderate, sometimes it's very severe symptoms. Okay, along with that, reversible airflow obstruction. Bronchial hyperresponsiveness. A lot of patients will say they're allergic to it, but it's when you are exposed to whatever irritant that triggers your asthma exacerbation, that's your airways are being hyper responsive to that thing. Okay, whether it's grass, mold, chemicals, smoke, shellfish, whatever it is, it's causing this bronchial hyperresponsiveness. And then underlying inflammation, especially in severe chronic asthmatics, they will always have a low-lying level of inflammation in their lungs. It may manifest as wheezing, okay? Everybody knows wheezing is an expiratory, sonorous type sound, okay? It's musical. Yeah, I'm not gonna play wheezing because you guys don't know it by now. Chances are you're not gonna recognize it. May manifest as chest tightness. Okay, the patient says my chest feels tight. Generally, when they say that, they mean they can't get a breath in. It just is really hard. It's hard to exhale, and they need to take another breath. And when they try to take a breath in, they're already hyperinflated. Okay, so they're wheezing of the exhale. They can't get a big breath in because they're air trapping. Okay, this causes shortness of breath. And then some patients, it just a cough, okay, an irritant to the lungs, and then they just cough. It can be triggered by exercise, can be triggered by allergen exposure, like all those different allergens I mentioned. It can be triggered by viral infections. Okay, all of those things can trigger an exacerbation of asthma. Symptoms vary over time. They could vary day to day. And like I said, a child might be diagnosed with asthma. And I had a physician once told me that the diagnosis or definition of asthma is wheezing more than once. I think that's pretty a loose definition, but also if a patient is being treated for wheezing, shortness of breath, and they're given a bronchodilator and it reverses, and this continues over time, okay, this is a pretty good indication that they're going to have a chronic diagnosis of asthma or diagnosis of chronic asthma. Asthma tends to worsen at night or early in the morning. And hallmark for diagnosis of asthma are physical exam and history. Okay, so all the things leading up to this exacerbation or attack, if you want to call it. The physical exam, including breath sounds, and then spirometry. Okay, so doing PFTs on this patient is a gold standard of diagnosis. Okay, so table 8-1, straight from your book. is the diagnostic criteria for asthma in adults, adolescents, and children age 6 to 11. Physicians are very hesitant to place a label of asthma on a child until they've had recurrent wheezes, recurrent shortness of breath, recurrent chest tightness. So if you look here in this table, and you guys can read it, I don't have to read it to you, but history of variable respiratory symptoms, and it lists all these symptoms. And then confirmed variable expiratory airflow obstruction. Okay, so we're looking at spirometry, FEV1 over FVC numbers, reversibility, pre and post bronchodilator, methacholine, histamine, or cold air or exercise challenge. Okay, all of these things can be used in diagnosis. And here's spirometry measures, and it's kind of comparing asthma to COPD, okay, and what the spirometry looks like. And then this, if you remember from the COPD section, we have asthma COPD overlap syndrome. Okay, so patients have COPD, emphysema, chronic bronchitis going on. They have asthma symptoms. Maybe they grew up with asthma. Maybe it was something that they've lived with their whole life, and then they developed emphysema on top. So they have this ACOS, asthma COPD overlap syndrome. So diagnosis of asthma in adults requires this stepwise approach. Okay, so you have a patient with their history and physical exam that's showing symptoms of asthma. That patient could even have a genetic history, their family history of asthma. So you identify this patient as at risk. Okay, we do that detailed history and physical exam, pulmonary function tests, comparing all of these values along with pre and post bronchodilators and all this different tests that we can do can kind of classify that patient into, are they asthmatic? Okay, is it reversible? When we treat them, do the symptoms go away? Do they have COPD? Okay. Do they have these underlying symptoms and they don't reverse? They don't go away. They're alleviated, but it's not completely reversible. Or do they have a little bit of both, ACOS? So clinical signs and symptoms. No feature is unique to asthma. Okay, no feature or symptom or sign and symptom is universal in all asthma patients. Okay, one of the classic points or parts of asthma is that if you identify the trigger, whatever is causing the bronchial smooth muscle constriction, and that patient avoids it, okay, so they aren't having an exacerbation of their asthma, then that's generally a hallmark of the diagnosis of asthma. Classically, people with asthma present with wheezing, chest tightness, okay? Shortness of breath. If that's allowed to continue, they get tachypnea. They have prolonged expiration that causes that wheezing, accessory muscle use, okay? Retractions, pulsus paradoxus. Remember that pulsus paradoxus is a pulse that weakens abnormally during inspiration due to a large decrease in systolic blood pressure. And then in exhalation, it comes back to normal. So when the patient takes a big breath in, pulse weakens. When they breathe out, it comes back to normal. Okay, that's pulsus paradoxus. And then tachycardia can follow along because the heart wants to compensate for lack of oxygen getting to the tissues. So the longer the exacerbation goes on, the harder the heart has to work. Okay, there is a family history of atopy, okay, or atopy. Atopy is a genetic tendency to develop allergic diseases. Okay, so my husband's mother has horrible allergies. My husband has horrible allergies. As a child, he basically lived on turkey hot dogs and Gatorade. He was allergic to all meats except for turkey. He was allergic to anything that had a feather. He was allergic to grass, pollen, um, cats, fur, all of these things. Fur meaning like fir trees. Now he since has outgrown some of these, but still has allergies as an adult. History of asthma as a child or reactive airway disease as a child. And then some triggers include exercise. Okay. Exercise could cause a release of histamine and other chemicals that can cause bronchial smooth muscle spasm. Cold air, exposure to inhaled allergens, work-related exposures. So all of these things can trigger bronchial smooth muscle spasm, causing that shortness of breath, wheezing, and the other symptoms of asthma. We talked about it being a genetic carried disease, or it could be a genetic disease. So it's affected by numerous genes and environmental factors, okay? And usually a combination of both. IgE responsive B cells, cytokine inflammation, HLA locus immunity, all these things are genetic. Not all of them are genes, but they all reflect back to what could cause asthma. And there's a lot of different causes. Okay, knowing the genetic signature of asthma-associated genes, what alterations they have, okay, during peak of asthma exacerbations might help predict severity of the disease and the response to specific therapies. So epidemiology, okay, let's talk about the disease or some statistics. Okay, so there's 25 million asthmatics in the US as of when your book was published. Prevalence of asthma varies around the world. Now, does this mean there's less cases of asthma around the world, or are they just not diagnosed? Asthma prevalence is more common in urban than rural areas. Is this because air quality is better in rural areas than urban? Maybe. More prevalent in poverty and large minority populations. Again, is this because you have a lot of people in a small area and it's more urban and you have more air pollution? Maybe, maybe not. Higher incidence among minorities. Most cases develop at an early age. Okay, so these are all just statistics. The pathology or pathophysiology of asthma, edema and cellular infiltrates invade the bronchial wall. Detachment of surface epithelial cells from basal cells. Okay, so all these things are rushing in. Increased deposition of collagen in the epithelium. You have hypertrophy and hyperplasia, so it's swollen, okay, and there's more in number of the smooth muscle. Hypertrophy of the mucus glands. Okay, this is what's causing that increased amount of secretions. Increased number of goblet cells, again, increasing the number of secretions. Marked over distension or hyperinflation of the lungs, and then thick, tenacious mucus plugs. Remember back to pharmacology, the three components of asthma are bronchial smooth muscle constriction, bronchial wall inflammation or swelling, and increased mucus production, thick, tenacious mucus plugs. Okay, remember those three components of asthma, not just the bronchial smooth muscle spasming. It's all three of those together that cause the decrease in airway diameter and then the wheezing on breath sounds. Okay, they have inflammatory changes. So I just mentioned that. Infiltration of eosinophils and mast cells, macrophages, T lymphocytes, airway walls, mucosa, and lumen. All of these contribute to inflammation of the tissue. And then those bronchial smooth muscle contraction. And there's a lot of different mediators that can cause or contribute to the bronchial smooth muscle contraction. Those include histamines, cytokines, prostaglandins, leukotrienes. And remember, if you think back to pharmacology, we try with these patients antihistamines, okay, drugs that will block histamines, the histamine receptors. We try drugs that will alter the cytokines. We try drugs that will inhibit prostaglandins. We try anti-leukotrienes or drugs that will inhibit leukotrienes. So all of these are part of that inflammatory cascade that if we interrupt in between that, we will hopefully prevent bronchoconstriction. So this picture, and you can read about it in your book, it's the asthma inflammatory cascade. Okay, so remember acute case or acute phase and late phase inflammation. Okay, so we have our antigens. They come in contact with your epithelial cells. Okay, macrophages. They chomp it up and release histamine and cytokines. B cells will affect the plasma cells, which then release hook onto the mast cells. The mast cells burst apart, release all kinds of chemicals, and all of these things lead to inflammation. So all of this could be happening at once, or maybe only one of these things is happening. So anyways, all of these contribute to bronchoconstriction, whether it be bronchial smooth muscle spasm, cell or airway wall inflammation, or increased mucus production. All three things lead to bronchoconstriction. So acute phase, we've talked about it in the past, just going to mention it here. The acute phase asthma is response to whatever that trigger is, okay? Whatever's triggering the bronchial smooth muscle to spasm and the bronchial wall to constrict, you have a response to that trigger, okay? It is very short-lived. You have bronchospasm with airway narrowing. In the acute phase, it responds very well to bronchodilator therapy. Okay. Over several hours. So if it's allowed to continue past that first 2 to 4 hours, then mediators are activated, causing persistent or chronic inflammation, and it leads you into the late stage of asthma. Okay. So that's 6 to 8 hours after your acute stage. You have a more severe or chronic reaction. It's more difficult to treat because now you don't have just bronchial smooth muscle constriction. You have inflammation, you have mucus, everything is working together to narrow the diameter of the airways. And you also have all of these eosinophils, basophils, neutrophils, T cells, monocytes. All these things have to be cleaned up or taken care of by the body before everything returns to normal. Okay, and then you can have airway remodeling. Okay, this might occur over time and limit the patient's asthma from being fully reversible. Okay, this is damage or loss of normal pseudostratified airway epithelium. Okay, so the normal cleaning escalator is damaged. You have an increased number of goblet cells. You could have fibrotic thickening of those subepithelial reticular basement membranes, so the membrane's getting thicker. Increased number of myofibroblasts. Angiogenesis, increased airway smooth muscle mass, and increased extracellular matrix. Okay, these things all equal permanent airway structural changes. Okay, this can occur over time. And again, it can limit that patient's asthma from being fully reversible. So these are chronic, permanent changes. Now we're going to talk about phenotypes. What does phenotype mean? It just means categories or classifications. Okay, so phenotypes are a cluster of characteristics that define a disease or subset of the disease. Okay, some of them may have common characteristics, but you can kind of break asthma down into several different subgroups or phenotypes. First one, and the most common and the most relatable, is allergic asthma. Allergic asthma is defined when you have a positive allergy test. Generally, that's one of those scratch tests. They can do it on your back, they can do it on your thigh, on your forearm. But a scratch test is when they prep certain gridded areas on your body, wherever they do it, and they introduce little bits of pathogens to see if your skin reacts to them. Allergic asthma is diagnosed in younger patients. It has an early onset. It varies with the season. And generally, there are specific allergy triggers, such as grass, pollen, mold, cats, dogs, shellfish, etc. Things that you can point to. When I come in contact with this, I have an exacerbation of my asthma. There can be non-allergic. Okay, these patients have a negative allergy test. They have a normal or low IgE level in their blood. Usually these are later diagnoses or adult onset, and there's no strong family history, so it's not even tied genetically. There can be infection induced. Okay, so cause of new onset infection induced asthma. One of the big ones is RSV or respiratory syncytial virus. It can be caused by rhinovirus, parainfluenza, metapneumovirus. Okay, this can cause that new onset, but you can also have exacerbations, like or recurrent flare-ups. Many times when patients have a severe RSV infection, especially kids, and it has led to bronchospasm, they say, well, I have a tendency to get it easier. Okay, so causes of exacerbations or flare-ups can happen. And then causes of persistence, in other words, prolonged or continued symptoms of asthma, adenovirus, chlamydia, and mycoplasma. There's also exercise-induced bronchospasm, probably the hardest to diagnose because you have to catch it in the act. Okay? And really the only way to diagnose it is to do an exercise stress test with the patient and hope that they have a bronchospasm during that exercise. Generally, and I said during, but generally the peak bronchospasm happens 3 to 5 minutes after they stop exercise. Okay, so it doesn't happen a lot of times during it, unless it's a really long exercise session. It'll happen afterwards. There's a cough variant, okay? And this is really interesting because I worked with a physician who was a pretty severe asthmatic, but never wheezed. He always had clear breath sounds. However, he had a chronic, persistent cough. And it was never a strong or violent cough. It was just a persistent, and just a little cough. So in this phenotype or category of asthma, cough is the main or only symptom. There is no history or genetic component to it, so no ATP, and no diurnal variability. So it doesn't matter whether it's during the day, during the night, no matter what time of day it was, no matter what time of year it was. He could just start having a cough, and this was a symptom of his asthma. And the last one we're going to talk about is super rare, but you may hear of a patient having this aspirin exacerbated respiratory disease, or AERD. This is when patients who take aspirin or other nonsteroidal anti-inflammatory drugs will develop these symptoms of asthma. Okay, so they'll have a bronchospasm or bronchoconstriction after they take some type of anti-inflammatory drugs. So common risk factors for development of asthma. Major risk factors include genetic links or a family history of asthma, age or gender. Boys are usually diagnosed less than 20 years of age, women greater than 40 years of age. Not sure. In childhood, gender is a risk. Boys have a higher risk for asthma than girls, but after age 20. Or after age 40, I apologize, more common in women. And then exposures. And we've talked about these multiple times, and these are just a small amount of exposures, whether occupational or just from around your house. These can all be a risk factor for developing asthma. Complications. These occur most often when asthma is uncontrolled and during exacerbations. Okay, so that's kind of obvious. If you control your asthma, control your symptoms, taking your meds, staying away from triggers, you are not going to have complications. It does interfere with activities of daily living, or ADLs. So, you need to educate your patients to, again, avoid their triggers, take their maintenance medications, always have their rescue inhaler with them. If you know someone that has asthma, next time you're with them, say, hey, do you have your inhaler? Okay, that's one of the biggest problems of patients with chronic asthma, is they don't take their meds with them. And then when they need them, they don't have them. And then that flare up or exacerbation just continues to get worse because we aren't intervening in a timely manner. Patients can get respiratory failure. Okay, so this is late. And then death, obviously, is a very severe and not very common complication of asthma, but can happen. Circumstances increasing the risk of death from asthma, okay, previous intubations and or mechanical ventilation from an exacerbation of asthma. Okay, so once a patient's been intubated once with asthma, you really got to watch them when they have an exacerbation again. ICU admissions for asthma in the past, again, same thing. If they were sick enough in the past from exacerbation to be admitted to the ICU, chances are they could happen again. And then 2 or more hospitalizations from asthma in the past year. Okay, all of these circumstances show a severe case of chronic asthma, and they also show how quickly this certain patient can get very, very bad very, very quickly. Some more circumstances increasing risk of death from asthma: 3 or more ER visits for asthma over the past year. If the patient has comorbidities or other associated diagnoses, for example, pneumonia, heart disease. Okay, so comorbidities, other things that can make that patient sicker faster. If patients are non-compliant or have poor adherence to their treatment, okay, this will increase the chance of death. Use of more than 2 meter dose inhalers of their short-acting beta agonist per month. Okay, so if that patient is just taking puff after puff after puff of their albuterol or their Combivent, and they're just breathing through MDIs, that means that their symptoms are not being controlled. Their symptoms aren't controlled or adherence to treatment. Okay, this leads to long-term chronic asthma and will contribute to a higher chance of them dying from it. low socioeconomic status or urban residents, okay, if they lack medical coverage. And then sensitization to the aeroallergen Alternaria alternate. Okay, and that's just a fancy word to sensitization. So your body is has become kind of immune to fighting off an aeroallergen, which is airborne, and Alternia alternate is a fungus. Okay, so if your body is sensitive to this airborne fungus, it's very hard to treat and it could lead to death if you have asthma. Phew, now diagnostic testing. Okay, so it might be apparent from symptoms and variable and intermittent airway obstruction. Okay, so recurrent exacerbations of these symptoms, recurrent um, periods of having these symptoms. That might make it a very apparent diagnosis of asthma, but it might not. Confirmed by objective measurements of lung function or pulmonary function tests. So, pulmonary function testing is recommended for all patients to confirm the diagnosis of asthma before initiation of therapy. Now, is this realistic that we diagnose them before we initiate any therapy? Probably not. However, once they have presented with the symptoms, we've helped them control the disease, then pulmonary function testing is really, really, really important to establish a baseline and then to follow the progress of their disease. Spirometry can demonstrate obstruction and assess reversibility in patients 5 years old or more, as long as they can follow the directions you're giving them. And we all saw with the PFT machine, you can do the birthday candles in the cake, you can blow the leaves off the tree. There's a lot of different fun incentives for kids. So as long as they can follow directions, they can do a pulmonary function test. The earlier we get that baseline established and we can track their disease process, the more effective their long-term therapy is going to be. Pulmonary function testing shows an obstructive pattern. It'll also show reversibility. Okay, we do pre and post bronchodilator pulmonary function testing. It'll show reduction in the forced expiratory volume in 1 second, FEV1. It'll show a decreased FEV1 over FVC ratio. Okay, generally, patients with asthma have a normal diffusing capacity, DLCO. Okay, so we won't see any change in that. And then lung volumes can be normal or elevated total lung capacity and FRC because of hyperinflation. We'll show an obstructive pattern in which the FEV1 increases more than 12% and at least 200 milliliters from baseline following the bronchodilator. So post bronchodilator, we want to see a 12% increase in your FEV1. Okay, that's a hallmark of asthma, is the reversibility. Improvement in the FEV1 verifies the responsibility, so it's documented. Okay, our first FEV1 was, I'm just going to pull a number out, 70%. Okay, we gave them a bronchodilator. 10 minutes later, their FEV1 was at least 82%. Okay, we had a 12% at least increase in your FEV1. It shows reversibility. If your patient is not currently experiencing bronchospasm, we can do one of those bronchial challenges, either the cold air or the methacholine, or there's a whole list of them. Okay, once they say, for example, say we do a methacholine challenge, we give them their dosage of methacholine. And as soon as they have a 20% fall in that FEV1, we give them their bronchodilator, and then we look for the increase in FEV1 by 12% after that. Okay, so if they aren't in the middle of a bronchospasm, we can give them a bronchospasm and then hopefully reverse it. Peak expiratory flow, okay? Peak flows is an objective assessment of the severity of exacerbation. Normal values, you guys have done this, we did it in class, depends on gender, height, and age. And then generally, it's below 200 liters per minute, severe obstruction. Okay, again, like pulmonary function tests, peak expiratory flow is patient dependent. So they have to give a really good effort in order to get an appropriate or accurate number. It's a great way for chronic asthmatics to track their disease process and to know how they're doing on a daily basis and when they need to go to the hospital, when they need to take an extra treatment. Okay, as long as they're following what their norms are and they're tracking their peak flows, that's an easy way for them to do that at home. And laboratory testing, there's no definitive diagnostic laboratory testing. Okay, there's none. Glucose levels need to be checked and monitored for hyperglycemia, okay, especially if they are on steroids, glucocorticoid administration. Laboratory tests only provide supportive evidence. If there's an increase in the serum IgE, okay, this means there's some type of allergy usually. So if you have a genetic history of asthma in your family, and that patient, okay, the child or teenager, whatever, and that person is exhibiting symptoms of asthma, then you want to check their allergic portion first, okay? You do that skin test, allergy skin test. And you do a serum IgE to see if there's an allergic type possibility, okay? But this is all on patient history, family history, then the patient's having symptoms, then we're going to proceed to the allergy testing. We're going to draw an IgE and see if any of those things come up positive. Differentiating asthma from other respiratory disorders, especially COPD, can be challenging. Okay, so we have to put all of this information together. Now, I'm going to show you a video. There's another diagnostic test that's become kind of common or becoming more common. It's called fractional exhaled nitric oxide. And what it does is it examines airway inflammation and oxidative stress associated with asthma. Okay, this is a biomarker of airway inflammation. Okay, expired nitric oxide. Okay, it'll assist in assessing the etiology of respiratory symptoms, helps identify eosinophilic asthma phenotype, okay, so allergic asthma, help assess the response to inhaled corticosteroids, serves as a guide to use in the use of anti-inflammatory meds. Okay, these are anti-leukotrienes, some of the pills that patients can take instead of inhaled medication. It assists in the evaluation of adherence, okay, or compliance to anti-inflammatory meds. Again, these are the oral meds. And assess whether airway inflammation is contributing to poor asthma control. So I'm going to pull up this video and we're going to watch. So hold on just a second.
FeNO stands for fractional exhaled nitric oxide. FeNO is a very safe, very effective test that can help detect allergic inflammation in your airways. Allergic inflammation is a key part of many people's asthma and can help us to make sure you've got the right diagnosis and the right treatments. FeNO is used alongside other tests, but also with a detailed clinical history. And your healthcare professional will use them alongside FeNO to help diagnose asthma in adults and for children over 5 as well.
The first time I had the FeNO test, I was slightly apprehensive. But the nurses that were there explained everything to me, made me feel relaxed beforehand, and explained that it may take 1 or 2 attempts to get the hang of it, but once you do get the hang of it, it's very simple. After the test, I felt completely fine. The test itself is so mild that it doesn't really have any problems that afterwards you need to take that recovery time. And also I felt relieved because there was an answer to my symptoms and I knew I was being put on the correct pathway.
So the Pheno test can be performed anywhere where there is a Pheno machine. Most hospital asthma clinics have had Pheno machines for years, and now GP surgeries are starting to get them as well. Pheno is a test that can be done by any healthcare professional who's had the right training. The Pheno test takes literally 1 to 2 minutes. Once you're settled and relaxed, you'll be asked to take a breath in, and then you'll breathe out into the machine, which will be able to detect how much nitric oxide you've got in your airways. The results come up on the screen within a minute or 2. Every person doing the Pheno test will use a new, clean, hygienic mouthpiece. These are disposable, so they're not reused. Each clinic as well will have its own protocols so that the staff, the room and the machine are all kept clean, healthy and safe for your use.
Compared to other asthma tests that I've had, the Pheno test is a lovely, simple breathing test. It doesn't trigger my asthma symptoms and it is far less hard work than a lot of the other tests are.
High Pheno level tells us that there's some allergic inflammation in your airways. This is important because this can tell us whether you've got asthma, but it also tells us that your lungs are more likely to be set off by triggers and you're perhaps more prone to having an asthma attack as well. Really important though is having a high Pheno level does tell us which medications work best for your lungs. Having a low Pheno level doesn't rule out asthma. What it does though is tells us there isn't any allergic inflammation in your airways. You might have a different cause for your symptoms, or you might have a non-allergic type of asthma that needs looking into as well. There are a few things we ask people not to do before having a Pheno test. So for 1 hour before having the test, try not to exert yourself, try not to drink any hot drinks, especially avoiding caffeine and alcohol, and do not smoke for an hour before the test either. There are a few foods as well which can affect a Pheno test. So for 3 hours before having your Pheno test, try to avoid green leafy vegetables such as celery, leek, spinach, cabbage, and also avoiding beetroot as well. Take all your medicines as normal before having a Pheno test, but do let the person doing the test know whether you're taking some oral steroids, if there's been any changes in your medication, or if you've got any illnesses at the time. At your next routine appointment with your GP or your asthma nurse, you can always ask them whether they've got Pheno available yet. For more information about Pheno, visit the Asthma UK website. You can also call our helpline and speak to our specialist team about whether you think Pheno would be useful for you.
All right, so that's something kind of new. I think it's gaining some ground, but I wanted to make sure you guys saw that video on Pheno, or fractional exhaled nitric oxide. So chest radiograph, it's not necessarily diagnostic for asthma. However, you may see signs of hyperlucency. Okay, so it seems like it's a lot darker. Okay, depressed diaphragms or flattened diaphragms from hyperinflation, and then increased retrosternal spaces. So you might see that. And I have some pictures of x-rays here in a little bit. Pulse oximetry, particularly valuable in symptomatic asthma. Okay, so we want to follow and make sure the patient's oxygenating. They can have decreased oxygen saturation while breathing room air. Okay, usually this is associated with a need for hospitalization, necessitates getting a blood gas just to follow their progress, and then signals the need for aggressive therapy. Okay, so if they are having enough bronchospasm that their oxygen saturation is less than 90%, we need to give them some supplemental oxygen and get their bronchioles to open back up by whatever means we can to get their oxygen saturation back to normal. ABGs, they're very essential in severe cases. A poor ABG indicates the need for more aggressive management, obviously, and it's helpful in evaluating the PaCO2 in patients that are hypoventilating. Okay, so as their asthma exacerbation moves on and continues and is not reversed, okay, initially they're going to be hyperventilating because they're trying to breathe fast to get more oxygen in and get more CO2 off. They will hyperventilate, but as their body gets tired, they will start hypoventilating and CO2 will rise. Okay, without intervention, you'll have a widespread AA gradient, okay, widened AA gradient, okay, starts getting bigger and bigger and bigger, causes PaO2 and SaO2 to drop. And then the PaCO2 begins to falsely normalize and pH decreases. Classification of asthma severity. Okay, so the component of severity, is it intermittent? Is it mildly persistent, moderately persistent, or severely persistent? Okay, so do they have occasional exacerbations? Do they have a low-lying bronchospasm or bronchoconstriction all the time? Is it moderate or is it severe? Okay, so we want to make sure that that patient is aware of their symptoms and what's going on with them. It's the level of impairment and the number of asthma exacerbations, okay, especially if they require corticosteroids in order to reverse it. Okay, so impairment's based on number of days with symptoms, frequency, and waking up at night or nocturnal awakenings. The amount of short-acting beta agonist bronchodilator use. Okay, is it interfering with your normal activity? And then your lung functions, your pulmonary function tests. Now here's those x-rays that I talked about. These are just a couple different x-rays, show a couple different symptoms, but there is no specific hallmark asthma x-ray. Okay, you may see increased lung markings. They will all be hyperinflated, especially during an exacerbation. Okay, so you guys can look at these AP and lateral films, okay, that show that hyperinflation. Here's another little table, shows classification of asthma severity. Okay, the different medications we can use, why we would use them, and some comments or some specific reasons that we use them. Okay, starting with inhaled short-acting beta agonists. That's our frontline, first-line treatment. That's the lowest level of treatment for our asthmatics. Going into inhaled short-acting anticholinergics or Atrovent, okay, or combined therapies. Next down the line, glucocorticoids, okay, orals, prednisone, prednisolone. Okay, if that doesn't help, magnesium sulfate, very short-term acute care management. Okay, it has bronchodilator activity. You don't see it used very often, but maybe in conjunction with a severe exacerbation. Inhaled corticosteroids, this is for long-term management. These are our chronic patients. Inhaled long-acting beta agonists, again, chronic patients. And you can go all the way down and you can read these. Okay, this table shows you a level of control based on impairment, based on risk criteria, based on patient history. So treatment and management of asthma, we have two main focuses for treatment and management. We want to treat their acute exacerbations, and we want to make sure to treat them long-term so that they don't keep coming back, okay? So treat what's going on right now, prevent what could happen in the future. Acutely, you guys should know this, we use short-acting beta agonists, okay? It relieves acute bronchospasm. These include albuterol and levoalbuterol. Those are our two most common. We can give inhaled short-acting anticholinergics. In addition to albuterol, we can give Atrovent or Duoneb or Combivent, okay? We know that those, the beta agonists and an anticholinergic working together gives us an enhanced response, okay? 1 + 1 = 3. So when we give them individually, they work great. When we give them together, they enhance each other. So we get a better response. Acutely, they could get magnesium sulfate. It does have bronchodilator activity. Okay, again, don't see that very often, but some physicians are very fond of that treatment regimen. Okay, they can get systemic glucocorticosteroids. Okay, they have an anti-inflammatory response. They can get them by IV or oral, depending on the severity of the patient's exacerbation. Long-term, patients get inhaled corticosteroids. They're anti-inflammatory. They last for a long period of time. They keep that patient controlled. Okay, so these are all the controller category of drugs. Okay, those inhaled corticosteroids, there's multiple levels. Okay, so the dose depends on the severity of the patient's exacerbation and their disease process. And they can take inhaled long-acting beta agonists, okay, formoterol, salmeterol. You don't take them in place of your short-acting beta agonists, okay? It's your long-acting controller, and then they always have a short-acting beta agonist as a rescue. You guys already know this. We did this in pharmacology. Okay, combination drugs, LABA and corticosteroids, LABA and LAMAs, and then leukotriene modifiers, okay, montelukast, zafirlukast, and Xyluten. Okay, those are all our oral tablets that help to control the chemical release. Methylxanthines, okay, we don't see that very often anymore. And then immunomodulators, okay, these are injections, and we don't see those very much anymore either, but for very severe chronic asthmatics, you may see those used. Another thing that we're going to talk about, and they talk about in the chapter in your book, is bronchial thermoplasty. And they actually do this at Lima Memorial for sure. And they may be doing it at St. Rita's too, but I know that one of the physicians at Lima Memorial does it. And what it does is it reduces the amount of excessive smooth muscle in the airway. So they go into the airway and they basically cauterize or heat up that smooth muscle, and they diminish the amount of smooth muscle that can spasm. It's minimally invasive. They do it with bronchoscopy. Significantly can improve the quality of life of severe asthmatics. Been shown to reduce asthma exacerbations and respiratory-related emergency department visits. And we're going to watch a video on this as well. So let me pull that up.
Asthma is a chronic inflammatory condition of the airways of the lungs, where patients tend to get chest tightness, wheezing, and cough. For some patients with severe asthma, medication may not be enough to control all their symptoms. For these patients, bronchial thermoplasty is a novel treatment approach. My name is Zaid Zoumat, staff physician and interventional pulmonologist at Cleveland Clinic, Abu Dhabi, part of the Respiratory and Critical Care Institute. What bronchial thermoplasty does is reduce the thickness of the smooth muscle by treating it with a gentle form of heat or radiofrequency, therefore improving both the size of the airways when the patient is well and reduces the ability of the airway to spasm during asthma attacks. All other asthma treatments involve medication to try to reduce the reaction of the airways to the various triggers that cause asthma attacks. But bronchial thermoplasty is the only treatment to actually change the structure of the airway itself by reducing the amount of smooth muscle in the airways. Bronchial thermoplasty is performed in 3 bronchoscopic sessions, 3 weeks apart. In the first treatment, the right lower lobe is treated. 3 weeks later, the left lower lobe, and in the last treatment, both upper lobes at the same time. The treatment is delivered for a maximum of 10 seconds to each area, so it's just enough heat to reduce the amount of muscle in the airway without causing any problems to the lining of the lungs. Many patients start to notice benefit in terms of their chest tightness, wheeze, and cough, even after recovery from the first of the 3 procedures. Each bronchial thermoplasty treatment takes between 45 minutes and 1 hour to complete. The bronchoscope, which is a long thin tube with a camera on the tip, will be passed through the mouth into the lungs, and a visual inspection of the airways will be performed. The bronchial thermoplasty catheter passes through the bronchoscope, and the heat will be delivered to the airways that are to be treated. At the end of the procedure, the catheter and bronchoscope are removed from the patient and the patient allowed to wake up. The patient will be seen in clinic 1 week after each procedure and the next treatment planned if they are well. Bronchial thermoplasty is a very safe procedure. Other than the possibility of an asthma attack around the time of the procedures, there are no major complications that can be associated with bronchial thermoplasty. It's extremely rewarding to be able to offer these patients a one-off treatment which has lifelong benefits and enables patients to get back a certain quality of life that they have lacked for many years.
So again, this is a procedure that uses a bronchoscope, and it has been shown to improve quality of life in patients who are experiencing chronic asthma symptoms. Prognosis of asthma, it is not curable, but if diagnosed, if the patient's compliant, if the patient is on a really good treatment regimen that's tailored to his or her asthma, it is controllable. Asthma depends on several factors, including the severity, the chronic symptoms, hormonal influence, and actually elevated body mass index. So patients that are obese have more severe symptoms. So the bottom line is controlling the patient, their medication, and their activity level. Pulmonary rehab can help. All of these things tie in together to say what the prognosis is and what the disease process is going to follow. So that's it for today. And I hope you guys enjoyed the lecture and have a great week.